I'm Professor Mandy Mcclain. I'm one of the 4 Vice Presidents of the Royal Society of Edinburgh. And the Royal Society of Edinburgh was created in 1783, and it's an educational charity registered in Scotland. It's independent, it's non-party political, and it does many activities to provide the public with education and with benefit. We have a stringently peer-elected fellowship of over 1,600 scientists who are all top experts in their field of expertise, of which we cover many, many different fields. So I'm here to welcome you all tonight to this event. Thank you very much for coming, and I'm sure you're going to have a very interesting and stimulating evening. There is a social hashtag up on the screen here. For those who are social media savvy, this is the hashtag for this event, for those of you who are interested in that. I'd also like to give a vote of thanks to the people who have supported this and funded this meeting. That is Warren's Wish, the charity Warren's Wish. And also the Royal Society of Edinburgh's Drug Absorption Foundation Fund have helped to support this evening, and we're very grateful to them also. Importantly, we're going to have a comfort stop at 5 to 7 for about 5 minutes, for those of you who'd appreciate that. And that's my time up, you'll be pleased to hear. And my greatest pleasure now is to introduce the chair of the session, who's going to do all the hard work for us this evening. And it's with great delight that I welcome Lorna Marson, who is a reader in transplant surgery at the University of Edinburgh. She is currently the president of the British Transplant Society and also an honorary consultant at the Royal Infirmary in Edinburgh. So welcome, Lorna.
Thank you very much. It's my great pleasure to be here this evening and to welcome you all here this evening. It is an exciting time to be talking about innovations in transplantation because there are many and they are varied. And our speakers this evening are really going to illustrate some of the major innovations that are ongoing. And I think what is really exciting about the topics that we're discussing is that they have the capacity to make a real difference to patients within the next 5 or 10 years. And I think that is quite an unusual position in which we find ourselves as medical researchers. So it is with great pleasure that I welcome you here this evening to this session on innovations in transplantation. And without further ado, I will invite our first speaker to the podium. Professor Steve Wigmore is a professor of transplantation surgery here at the University in Edinburgh and is the president-elect of the British Transplantation Society. I wouldn't like anyone to think that Edinburgh is taking over the UK in transplantation, but there it is, and I'm delighted to be working with Steve on that. Steve did his undergraduate training in London, and really quite early on in his career was lured to South East Scotland, where he completed his both surgical and scientific training with a focus on the liver. And he continues to work in very active clinically in liver transplantation and in other types of liver, pancreas and biliary surgery. So Steve, it is my great pleasure to invite you to give us a state-of-the-art lecture on abdominal organ transplantation. Thank you.
Thank you very much, Lorna, and thanks very much, everybody, for coming. So I'm going to just take you on a quick trip to look at the landscape of liver and kidney disease before transplantation came along. I'll give you a very, very brief history of transplantation. I think we need to talk a little bit about immunity, rejection, and immunosuppression, which are key problems in transplantation. And then I'm going to do a whistle-stop tour through some recent highlights in abdominal organ transplantation. So this is what the landscape looked like for patients who had kidney disease or liver disease in the 1960s and 1970s. Hepatology wasn't even a specialty until the late 60s, and kidney disease was relying on very antiquated and Heath Robinson type dialysis machines to try and keep people alive, but actually really it was just palliating their disease. And there was really, both of these diseases, chronic liver disease and chronic kidney disease, were effectively palliative diseases. So transplantation was really needed, and it was 1954 in the Brigham and Women's Hospital that Joseph Murray did the first kidney transplant. And Edinburgh did the first kidney transplant in the UK in 1960 between two identical twins. And that really put Edinburgh on the landmark as a transplant centre. There were visitors from all over the world who came to see the transplant unit here. 1967 was the first liver transplant that was successful. Tom Starzl had pioneered this innovation, and actually the first number of patients, 3, 4, 5 patients that he operated on, all died either on the operating table or shortly afterwards. And it was in 1967 when the first patient actually survived liver transplant. And the following year, there was a successful liver transplant in the UK in Cambridge by Sir Roy Khan. Pancreas transplantation came along in 1979 in Minneapolis, and it wasn't until 1990 that the first islet allotransplant happened in Pittsburgh. So when we think about medicine, we think about people like Hippocrates, the father of modern medicine, who lived between 460 and 370 BC. And when you think about transplantation, it's actually only been around for 6 decades in the case of kidney, and considerably shorter in other specialties. So it's a really new specialty in the history of medicine, and it's a really exciting one in which things are happening very, very fast. So let's talk about immunity. We all have an immune system, and this is there to protect our body against infection and cancer. And it works by recognizing the difference between cells that belong to the self and cells that are foreign, and which is quite a simple concept, but quite complex in its articulation. Unfortunately, foreign includes transplants, and so when people started doing transplants in animal models, they soon realized that rejection was a big problem, and grafts were lost because they were non-self. And so early attempts at immunosuppression were quite brutal. So they included radiation therapy, whole body radiotherapy, which affected the bones, caused bleeding from the bone marrow failure, and made people profoundly immunosuppressed and susceptible to infections, such they had to be isolated for months afterwards. This was used in combination with high-dose steroids, which have a myriad of side effects and are really quite unpleasant drugs. And the first sort of more modern approach was Antipsychotic Globulin, and this is a picture of a vial that Keith James, who's a fellow of this institution, made back in the 1960s. And this was actually a crude method of wiping out immune cells using horse-derived globulins. And so there were all sorts of anaphylactic reactions to the horse serum if you had to have more than one dose. So I'll just show you briefly how we do it now. So if we look at a graft here, it has antigens which denote what's its identity. And these are recognized by T cells, which are lymphocytes, and they're part of the host immune system. And these cells recognize these antigens much more effectively if they have them presented on a plate by a cell called a macrophage. And then when they've recognized these antigens, they interact with other cells in this population, and you get proliferation of a swarm of cells which then attack the graft. So now we mentioned high-dose steroids. We use relatively lower dose steroids compared to what we used to do to affect this recognition stage. We use drugs called cyclosporin or tacrolimus to interrupt the communication between these initial recognition cells and the rest of the group. And we can stop the proliferation of the swarm using these other drugs. So modern immunosuppression has changed quite dramatically, and we use multiple drugs at quite low doses to increase the efficacy of the drugs, but also to reduce the side effects of them. And that's a huge benefit to patients. This is a graph which shows the number of patients on the waiting list in the UK and the number of organ donors in the blue and the number of transplants in the grey. And you'll see that, encouragingly, both the number of donors and the number of transplants is increasing year on year. But what's really impressive is that the number of patients on the waiting list is falling. And this has only happened really in the last 10 years. And there are numerous reasons why this should be so, but I'm going to pick on just one little reason, which is to do with kidney transplantation and altruistic donation. Altruism has been described as a uniquely human behavior. So this is the selfless giving of something to another person where there's no personal gain involved. And it's in direct conflict with evolutionary biology, which says that actually you should protect your own genes and never give anything away to anyone else, and it's a dog-eat-dog world. So when altruistic donors came along and said, I want to donate a kidney to anybody, just somebody to make somebody better, people thought they were mad. So it took quite a long time for society, particularly medical society, to actually realize that people were very well-meaning and very genuine. And so we began to facilitate this. And initially, altruistic donors used to just donate onto a waiting list, and so one patient would benefit from transplant. But since people frequently donate kidneys to directed donation to a husband or a wife, and sometimes they were found to be incompatible, we found that using an altruistic donor, we could actually make a transplant happen. So if this person wanted to donate to this one, but they were incompatible, we could say, well, they're compatible with this altruistic donor, so if we donate to the recipient that you wanted to donate to, you could donate to the waiting list. And people were happy to do that. And this is a short chain. And then this was multiplied into multiple donations and has been quite effective at increasing the number of transplants. And this is the increase in altruistic donation over the last decade. And it's things like this are actually making a real big difference to the waiting list for patients. So another innovation in kidney transplantation, which is hot off the press, is robotic kidney transplantation. And this involves a robot, which is set up here. These people are actually just putting the instruments into the patient, but the robot is going to do all the surgery. And it's controlled by surgeons sitting in the operating theatre or in another room nearby who control the instruments, which you can see in this little screen here. And this is magnified very greatly. It's about the size of the tip of your finger. And it's a wristed instrument, which the robot has. And it moves like this, which is really clever, because normally when we're using surgical instruments, we can't do that. And so it's able to do very precise surgery in very small spaces. And robotic kidney transplantation is actually really useful in big fat patients in whom it's technically difficult to do kidney transplants in, and that's where it's finding a niche. So if you want a kidney transplant in the future, you may need to speak to a robot near you. Liver transplants, I'm just going to touch on one real aspect of this, which is split liver transplant. So the liver is an asymmetric organ. You only have one liver, and it's quite a big organ. And people have worked out how to split the liver into two parts so that it can be transplanted into two individuals. And this has really transformed the landscape for children and babies with liver disease, who used to have to wait for a very small donor, another child, to die to have a suitable liver. And now they can have a liver from a split liver transplant from an adult. And the waiting list and the waiting list mortality for children has really dramatically dropped over the last 15 or 20 years. It's technically difficult, and I wasn't going to show too many gory pictures, and often a lot of reconstruction is required. But what this technique gave rise to was the ability to actually to use living donors to derive grafts for liver transplants. So a person can donate half of their liver to another person without detriment to themselves. And again, technically complicated surgery, but hugely beneficial for the recipients. And here are some of our Edinburgh patients who've benefited from living donor liver transplants. Multi-visceral transplant's been in the news this week. This is where you transplant a cluster of different organs, so the liver and the small bowel, or the liver, small bowel, pancreas, and stomach, as in this case. And this is a technique that has been used in a lot in children who've, this little boy lost his whole intestine as a baby when he had something called a volvulus, where the intestine twisted around itself and lost its blood supply. And he'd spent his entire life being fed through a drip in his arm, effectively. And as a consequence, his kidneys had failed and his liver has failed. So he was the grateful recipient of 5-organ transplant just recently. And there's a lovely video currently on the BBC website which shows him eating for the first time in his life and the excitement that he has with tasting food. Pancreas transplantation is something which, as I mentioned, started in the late 70s and is a way of treating, is usually transplanted with a kidney, is a way of treating patients who have diabetes and kidney failure. And kidney failure is quite a common end-stage complication of diabetes. And we know from work done by Mr. Iniscu, who's sitting in the front row, and Professor Forsyth, who's sadly not here, that patients with diabetes who have kidney failure do really badly on dialysis. And so pancreas transplantation, or simultaneous pancreas transplantation, has the ability to cure both of these problems in one fell swoop, and is hugely beneficial to the recipients. And we've just done our 250th pancreas transplant in Edinburgh, which we're very pleased about. The cells that actually do the business as far as diabetes is concerned are called islets, or beta cells that are constructed into islets in the pancreas. And islet transplantation came along in the 1990s as a possible solution to treat some forms of diabetes, particularly people who aren't aware when their blood sugar becomes very low. And the danger of not being aware when your blood sugar is very low is that you can become unconscious or crash a car. You could hurt yourself or someone else operating machinery. So it's really dangerous, and it stops people working, stops people driving. That makes them lose their independence. So islet transplantation uses islets isolated from a pancreas and then infused into the recipient, actually into the liver, where they lodge into little blood vessels in the liver and can reestablish a circulation and function. And in 2008, the Islet Transplant Consortium commissioned 3 centres. There's Edinburgh, Oxford, and King's, which actually isolates islets for the whole of the UK. And since it was started, there have been 203 transplants performed. And Edinburgh has been by far the most active centre in isolation and transplantation. These blue ninjas from the lab are the people who isolate the islets, and it's a very precise and important job that they do, and they're very good at it. And this is what the problem is. So if you don't have diabetes and you have a normal functioning pancreas with producing insulin, you keep your blood sugar incredibly tightly regulated between these, in the green zone there. A diabetic will be all over the place and swinging around like that. And this is what each one of these lines, I should say, is a 24-hour period. So this is someone who's had their first islet transplant. They're still requiring a little bit of insulin just to keep them within the safe boundaries. And this is after the second islet transplant, where they're completely insulin-free. And so it's a very effective treatment for diabetes. And virtually all of the patients who've been transplanted with islets in Edinburgh have become aware of hypoglycemia, which is the big thing that stops them being independent. So I'll just skip on. So now people are actually looking at whether it might be possible to print islets in a way that gives them a more effective survival, because one of the problems is that a lot of the islets that get transplanted just die and wither or get attacked by the immune system and taken out. And so people are now looking at bioprinting them into a capsule of alginate, which protects the cells from the immune system and shields them, to see if they can actually make them survive longer and make them more effective. So that's another evolving area. So abdominal organ transplantation is saving thousands of lives every year. The innovations that are being made at the moment are really important because they mean that more patients can benefit and for longer. Grafts are lasting longer. And some of these cell therapies and novel approaches may extend the reach of transplantation. So, thank you.
Thank you very much, Steve, for a fantastic overview and for really setting the scene for the rest of the evening. We're going in a little bit of a different direction now. We're going above the diaphragm, and I am delighted to invite Professor Nawar Al-Attar to give us a talk about heart transplantation. Professor Nawar Al-Attar, having trained in Paris and continues his links with the university in Paris, had moved to Glasgow, where he is a consultant cardiac and transplant surgeon and director of transplantation at the Golden Jubilee Hospital in Glasgow and director of the Scottish National Advanced Heart Failure Service. You're very welcome, Nawar, and we look forward to your talk about Une histoire de cœur. Thank you.
Thank you, Lorna. Good evening, everybody, and thank you for being here. So, as Lorna told you, I'm here to tell you a story of a heart, une histoire de cœur. But you'll see, une histoire de cœur is also a love story, so watch out. It's a story of a 50-year-old gentleman who was previously well. He was a teacher, an artist, and one day, while enjoying vacation in a remote part of Scotland, he had sudden severe chest pain. And for those of you who are watching that movie over there, this is, you can imagine this is an artery in his heart. And what's happening is a plaque of atherosclerosis, so that's coronary artery disease, ruptures and blocks off the heart, blocks off the blood supply to the heart. So at this point, the heart muscle is dying. Now, having had that heart attack, what would normally happen is that we would take that patient and run to the nearest cardiac center, go in and either suck that clot out and then put a stent in and keep it open and get blood flowing back to the heart. But in this, being in a remote place, there was no cardiac center next to him. So the paramedics, assessing the situation, gave him something to dissolve the clot. That didn't work. Thrombolysis doesn't always work. And indeed, his heart was now dying, and he was sicker and sicker. He couldn't breathe well. His heart wasn't pumping enough blood. He had to tube down his mouth, in his lungs, and he was put in a helicopter and sent to the Golden Jubilee. So arriving, he was taken immediately to the cath lab. That's where things happen. And you can see, well, in fact, what you can't really see is this is his angiogram. So we're here looking at the main artery of the heart. And normally, this lights up like a Christmas tree. It's full of branches and it gives blood to the whole heart. You don't see any of those. It's blocked off right here, right at the beginning. So 80% of his heart is now dying. It's not getting blood supply. The cardiologist on, Professor Mark Petty, was brilliant. He opened the artery quickly and had blood flowing back to his heart. But because of the time it had taken, his heart didn't recover. The heart muscle had died. And he was given lots of medication, pickled with what we call inotropes to try and get the heart to work. Nothing worked. And in fact, the only thing keeping him alive was this. Now, it's called the autopulse, but we call it the thumper. You can appreciate why. And indeed, it performs continuous cardiopulmonary resuscitation. It compresses the chest, and it was thanks to this compression, not the heart beating, that this gentleman was alive. Now, this obviously is not a sustainable situation, and indeed, for somebody who has now no heart function, the only way really to keep him alive is to put a new pump in, a new heart, preferably with a lung. Now, it just happens that we have that device. It's called an Ecmo device, Extracorporeal Membrane Oxygenation. This is it, and you can see it can give more than 4 or 5 liters of blood into the body, and it does have the 2 components that we were referring to. So one of them is this. This is the lung or an oxygenator, this one. And this is a pump. So this is the kind of the heart bit. So there's a pump, and there's, I would say a lung, it's called. And you can see it takes blood from the body, and it pushes it back in through here. It does what normally the heart and lungs do. It keeps the patient alive, and you can see the difference in color between arterial and venous blood. This one's black, more a bit red. And indeed, the patient's a bit better. He's better in a way that he is alive. It's true, because in fact, we had this young man who's had a heart attack, who, because of the delay, had lost his kidneys. His kidneys weren't producing anything and had to be on dialysis. He wasn't breathing, and we had to make a hole in his windpipe to keep him to breathe. He had required massive amount of blood transfusion. He was awake, and he told us he couldn't see so well, so we scanned his brain, and it turned out that he had a stroke. We had given him so much inotropes, these things that constrict your blood and try and push your heart, that the tips of his fingers died off. He couldn't eat and drink, so we had to put a tube down his nose into his stomach to feed him. And of course, on top of that, his heart wasn't working. So he was alive, but he was very, very sick. So we sat together as a team, as we would normally do. And in our multidisciplinary deliberations, we thought, you're really very sick. There's not much we can do for you. We would like to offer you a comfortable moment. And then when you're ready, we will turn the machine off and you will die. So in his final request, he said, yes. We had that discussion with him and his family. He said, before I die, I want to do something that's really important for me. And he said, I want to get married. So this is him. The nurse has decorated, this is an intensive care, in our intensive care unit. And you can see the nurse has decorated his room, and even the pump here. You can see the tracheostomy. This is the windpipe hole. This is the tube down his stomach to feed him. And this is him with his bride. The witness was the intensivist, the consultant in intensive care who was on call that day. And in fact, that was the best thing he ever did, because his kidneys recovered and he started producing urine. His visual disturbances disappeared and full neurological recovery. He started to breathe on his own. We pulled the tracheostomy tube out. He started to eat and drink on his own, so we pulled the nasogastric tube out, so he could now feed normally. And however, he still had a broken heart. So for somebody in that position, we look at long-term options and explore them. So he's on a bridge to something, and that something would be either transplantation, which obviously is the cure of heart failure, and we'll come to that maybe in a moment. But for somebody to have a heart transplant, somebody else would have to die, and that donor would have to have accepted to give his heart to a patient. We have on the shelf these devices, ventricular assist device. These are pumps. They're different types, and we can use them while somebody does, while we do find indeed a donor. And just one slide on ventricular assist device. This is how they work, at least the current generation. They have this rotor inside, and they're in this case. A magnet lifts the rotor up and starts spinning it, and blood flows. You see, we put it here right at the tip of the heart, and it takes blood from the heart and pushes it back into the circulation. Imagine it, and I apologize for the analogy, like a hybrid motor. So you've got the engine here, and you've got the electric engine here. Now this engine is dead. There's no petrol. The heart is infarcted. So it's all working on that electric engine right now. And indeed, they have these batteries, or they can be plugged into electricity, which powers this pump and keeps it going. And you can see it here in the X-ray. And in fact, one of the things we do when we put these patients on a VAD is we call the electricity supplier and say, whatever you do, do not cut off their electricity. And indeed, they cannot pay their bills, and that's not the right thing to do, but they could. You must also know that these patients don't have a pulse. So if you do ever meet a patient with a VAD and you don't feel a pulse, it's fine. They're alive. But really, the treatment for heart failure is a heart transplant. Now, heart transplant is done in these centres. Great Ormond Street does only pediatric, so children, and Newcastle does adult and pediatric. And this slide, although it's a few years old, shows you that there has been an increase in the number of transplants, but there's also a huge waiting list of patients in advanced heart failure that might have taken a dip, but it's still there, and these patients still await a heart transplant. Being a heart transplant isn't really on the list. Doesn't necessarily mean you will get a heart, and you can see that 30% of patients who are on a heart transplant get a transplant within 6 months, and even less than 50%, less than half patients 3 years down the line end up with a heart transplant. Sadly, some patients will die on the list, and others remain or are removed. And the reason for that is there has been a dip, although this goes back to a few years now, in a donation from brain death. And indeed, people can die because they have damage to their brain and the other organs are working and we can take them. That's the case for the heart. And I'll talk about the other type of death. But this decrease in brain death donation is about 30%. Well, it was about 30% a few years ago. But there was a great decrease in the number of heart transplants at the same time. Now, I'm happy to say, and I can see some of our organ donation nurses here, they will tell me this has now gone up, and indeed it's gone up considerably, but sadly this hasn't followed, certainly not with DBD, donation from brain death type of donors. And the other challenge is time. Now, when a heart leaves a body, we put it in ice in a picnic box, and then we run. We run because a heart in a picnic box is not going to last very long, and we do have maybe 2 or 3 hours to get it there. And indeed, if you look at 2 or 3 hours, the zone we can take hearts from is quite small. We've got far more patients that need hearts, and that zone is not long enough. Obviously, this is by car, but then plane transport also has time implications. So this ischemic time, the time that the heart stays in the picnic box, is crucial to us. And what we know is that if it goes beyond 2 to 3 hours, the risk of the heart not working is incredible. It goes up in a logarithmic fashion. And indeed, beyond 3 hours, every minute adds a risk of death following transplantation. So for us, time here is not money, time is muscle. With every minute, we lose more and more living cells in the heart. So time is muscle. So we've come up, we have now at our disposal a device that stops time. It's not a TARDIS, it's the heart in the box. It's also known by its trade name, the Organ Care System. And this is what it looks like. It's a big machine, and inside it has this disposable bit. It's called the OCS, but what it does, it gives the heart blood, warm, oxygenated, blood full of oxygen and nutrients into the heart, so that the heart is kept alive. It's no longer preserved by ice. It's kept beating. And indeed, that takes us from this. So this is a heart here, and you can see it. Isn't that beautiful? I mean, there's nothing, in my eyes, my wife maybe, but there's nothing more beautiful than a beating heart. And you can see blood flows into this part of the heart. This is the aorta. And just by giving it blood, the heart does the rest. It's beating away, and you can see it nicely. And it also means that our time pressure of 1 or 2 hours, or 2 or 3 hours, with cold preservation now means we can take the heart from anywhere, really. In fact, not just from Scotland, but anywhere in the UK. The machine gives us an extended time to bring the heart in. Now, the other concern with hearts is that there's been a significant increase in the number of death from circulatory death. So these are patients in whom the heart stops. The heart stops beating, the circulation collapses, and we die. The brain is fine. So while traditionally we've used hearts from brain death or DBD donors, what we've seen is that there's more and more patients who are dying from circulatory death, DCD, donors. And this is particularly true for Scotland. And I'd like to thank Leslie, who's in the audience, for providing the slide. And indeed, you can see we do more and more, in this country, in our country, there's more and more DCD donors. So besides the first transplant ever done 50 years ago by Christian Bernard, which was a DCD heart, ever since what we've been using for hearts are hearts from brain-dead donors. So these are patients with massive brain injury, either bleeding or trauma. And the reason for that is, well, a heart that wasn't beating, wasn't something we think would work. Well, we now know that it does. And this is a heart that, this is from a paper who are the leaders reading the technique. So the heart wasn't beating at all. And you can now see, after a small shock, the heart's starting to work. And we put it in the ex vivo perfusion device, in the organ care system, and off we go. We take it wherever we need. And this has revolutionized heart transplantation, being able to do hearts from DCD donors. So with the organ care system, with this ex vivo perfusion, we've managed to increase our DBD transplants because now we can take them with longer ischemic times. We can use them in hearts that sometimes we thought weren't perfect, and putting them on the device gave us time to assess them and look at them. We discovered a whole new source of hearts for us from DCD donors, and it means that less people die with organs that are otherwise wasted. And here you go, a beautiful heart ticking away. But I need to finish my story, right? You want to know what happened to our 50-year-old with a broken heart. Well, the thing is, he was in a place where if we couldn't sort that out, but he sorted himself. We know how to sort out hearts, so that's what we did. We mended his heart, and this gentleman was transplanted. Oops, here we go. So he was transplanted, and he was very happy with that. And if you remember, he's an artist. So he drove all our portraits, every single member of the team, and this is mine. It's the only official portrait of me. And for my last slide, this is his story. This is him very sick with all the tubes. And then this is him after his heart transplant, starting to recover. So you can see the tubes are coming out, all the devices that we were using to keep him going. He was on his back for so long, he lost his hair. I lost my hair for another reason, but he lost his hair by lying on his back. And then this is him. This is how, you can see the team. It really is a team effort. I can't emphasize how important these people you see on his sides, the nurses, the physiotherapists, everybody really, to help him regain strength after being, well, dead, being disabled, working back and doing things that he could never imagine he could do with a ventricular assist device. This is him shaving. He didn't have to worry about cutting himself and bleeding. A shower, believe me, this is, again, you can't appreciate how important it is for patients. We also did some things that I shouldn't really show in public, like the image that you'll see here, so I count in your discretion, but we allowed his dogs in the hospital. And then, I think this last slide really summarizes what it's all about. This is him back home, following a heart transplant. Thank you for your attention.
Thank you very much indeed for that. What is a fascinating talk, and really taking us on that journey of the patient, but bringing in so much of the innovation that's going on in heart transplantation. So thank you very much. And I think a point that all of us that work in transplantation would want to reiterate is the key team work that is ongoing, and as Noah alluded to, some of the members of the team are here in the audience. Some of our recently retired members of the team are also in the audience, but it is a real team activity. And it is with great delight, therefore, that I invite another member of the team, another surgeon, Mr. Gabriel Oniscu, who is one of my colleagues here at the Royal Infirmary of Edinburgh, where he is a consultant transplant surgeon and an honorary clinical senior lecturer. Gabby is also the chair of the Research, Innovation and Novel Technologies Group, which is a national group as part of NHS Blood and Transplant, which oversees the governance of transplantation in the UK. He's a multi-organ transplant surgeon, But really, he is here today because of his particular expertise in novel machine technologies, which you've had a little bit of a taster of from the previous speaker, but aimed at improving organ function. Gabby, it's a great delight to welcome you to the podium. Thank you.
Thank you very much for the invitation, and thank you for being here. Consider for 1 second that you need to buy a new car. But it's a car that has belonged to someone else. Which one would you rather have? Well, judging by the looks, I know which one I have. My wife might have something to say about it, but I'm actually not be able to get that simply because there may be reasons outside my control. But this is because we're looking at looks, and looks can be deceptive. So the real question here is, how do you decide which one is okay? How do you decide which car, or for that matter, which organ transplant, will work and will do what it's supposed to do for the rest of your lives? Now, for many years in transplantation, we were unable to ask that question, partly because the organs were of similar quality, but partly because they stick them in a box. And a box is just that. It carries the organs from one end to another, and it gives you no information about what they're supposed to do. Now, bizarrely, 50 years ago, machines were invented because people realized very quickly that a box is not good. But part of the problem that technology was very antiquated and did not allow any development. And you can see how big the machines were at that stage. Fast forward 50 years and we have an explosion of technology. Really, we have a revolution of what we've got out there. And having a technology that allows you to invent and innovate allowed us to ask a lot more questions, and they were very simple. And all of a sudden we're thinking, should we preserve the organs in the ice? Should we keep them at the body temperature? Should we give them oxygen? Should we give them nutrients? Should we do it in the donor? Should we do it in the box? So we have lots of questions that we need to answer. But the key question is, why do we need to consider preservation technologies other than telling us if the organ's going to work? Well, it's very simple. We don't have enough organs, so therefore we need to think any potential donated organ, we need to make most of them. We have seen a decline in the organ quality and now are already hinted at this increase in donation after circulatory death and the time of transport. And because of this constraint, there is a significant number of organs that are discarded. And let me give you an example from the liver world. So if you take 100 livers that are offered for donation after circulatory death, a number of them will be turned down straight away when the offer is made. Around 50% will be turned down when the surgeon looks at them, and we end up using about 36% of those. And because of this, there's also the issue is, how are they going to work? So let's take 100 patients who have received a liver transplant, okay? 26 of them, by the end of the first year post-transplant, will have significant damage to the bile duct, so much so that probably a quarter to a half of them will need a retransplant. Another 6 will have a liver that will never ever work and therefore require a transplant. And sadly, 6 of them will be dead by the end of the first year. So, with this stark problem, what are we really trying to achieve with machine perfusion? Well, we really need to wash the organs of the toxic metabolites that occur during the dying process. We need to provide nutrients and oxygen to sustain them being alive. And we've already talked a little bit about assessment of function, but more importantly is, what is the damage that an organ has sustained during the dying process, and how can we repair that damage? If we break the journey of an organ between the donor and the recipient, there are multiple points where you can have an intervention. And if I summarize those 3 and the intervention that are currently explored, you'll realize that I'll need to stay here till tomorrow. And I know we've got a comfort break, so I'm going to focus simply on 3 interventions that have been pioneered in the UK and are the very far end of the technology and the development, because they are preserving the organs at body temperature. The biggest change has occurred in donation after circulatory death, where in the past we simply used to go very quickly, recover the organs and cool them as soon as possible to stop the damage. Using the similar technology that Nawar has shown you earlier on, now what we do, we connect the donor, be it the abdominal compartment or now indeed the thoracic cavity to retrieve the heart, to an extracorporeal circuit. What this allows us to do is actually to oxygenate the blood and perfuse the organs for a number of hours to restore their quality and also to look at how they work. So what is the rationale here? Well, when we die, there's a period when the heart stops and the circulation doesn't exist there anymore. But during that period, the function of all the organs continue. Now, if you immediately after that start to cold perfuse, imagine coming out of a sauna and jumping into a cold pool at 4 degrees. You don't really be happy about that. Neither do the organs. And therefore, what we do, we introduce this period of reconditioning where we restore the blood supply to the organs. And what we do by that, we restore the energy supply. We allow the organs to tolerate better whatever damage they may sustain later on. And once they're reconnected to the blood supply into the recipient, they will work better. So how do we decide if it's okay? At the moment, this is what we do. We look at this liver. And if I show this liver to all of my transplant colleagues, this is from a DCD donor, they'll say, yeah, it's fine to use. In fact, this liver never worked. Nowadays, with NRP, we look at a composite and objective and dynamic function. So what we do, we look at how the liver looks. We look at how much bile and how good the quality of the bile is that the liver makes. And at a number of tests which will assess either the liver function or the biochemical environment in the donor to allow us to tell for sure if this liver is going to work once it's transplanted. Okay, does it work? Well, here is some experience from the 2 centres in the UK, the Edinburgh and Cambridge, that have pioneered this technology in the UK. And you have a comparison between the liver function of those that were transplanted with the normothermic regional perfusion or standard perfusion, standard practice. And what this shows you is that by using this technology, the injury that the liver suffers during the dying process is less, and it's much easier to recover. So let's go back to our 100 transplant patients that received the DCD. How much have we really achieved using the NRP? None of them had primary non-function, and none of them had biliary damage. So this is the technology that's groundbreaking and an approach that will change and revolutionize how we practice. But you may say, well, you've been selective, you couldn't do that for everyone, and so on and so forth. So the Birmingham group have decided to classify all the DCD liver transplants in the UK according to a combination between the donor and recipient. And they put in the lower risk, high risk, where the transplant could be done but with risks, and futile transplants. Do not try this at home scenario. And here's what happened when we plugged our data in using NRP. 1 low-risk transplant, and the rest of them are equally divided between futile transplants. So any risk score that you divide, you need to revise, because nowadays the technology has moved forward and we're able to save patients. It's not just an affair for the liver. Remember, we perfuse the entire abdomen and now with the heart as well. Does it work for the other organs? And here's data from France looking at the use of NRP. And what they questioned is whether using this approach makes the kidney work straight away. So reduces what's called delayed graft function, the period when the kidney is asleep before it wakes up. And this was the only factor that changed absolutely radically, 87% reduction in the risk of the kidney being asleep to start with. Furthermore, if you do use this novel approach, you are more likely that your kidney will have a better function, and that is preserved at 3, 6, 12, and 24 months. So it works for all the organs. So it makes most of the donated organs simply because we have better outcome, we reduce the need for retransplantation and increase the tolerance to storing the organs a little bit longer. So if we go back to our liver utilization, our DCD 100%, really using this approach in Edinburgh and Cambridge, we moved from 36% to 62% utilization. Now, if we were to rule this out nationally, what would that mean? 575 DCD donors in the UK last year, of which we used only 208 livers. With a very conservative estimate, 50 of those grafts had the complications that I've showed you earlier on. Again, with a 50% utilization and not 62%, we would be able to use 349 livers because we transplant more and we rescue those who have been damaged otherwise. There are 500 patients on the transplant waiting list at any time point in the UK. Okay, but this is applicable only for the DCD donors. What other options have we got? And this again has been in the news fairly recently. Normally, organs will go in a box, an ice, and brought to the transplant center. And during that time, we have damage of the energy engine of the organ and reducing energy supply. Now, the most innovative way of preserving the organs is actually putting them on a machine that mimics the environment in the body at normothermic temperature, providing nutrients and oxygenating the liver. This was in the news 2 weeks ago. It's a very important paper, and this is a machine designed by Oxford group called Organox. As you can see, the liver looks very healthy as it looked in a human body. But some of the key questions are, what this technology do? What it allows us to do? So first of all, same as we've seen in the NRP, it allows the liver to recover from the injury. And again, compared to the standard practice at the moment where the liver goes in a box, if we use the machine, there is a significant reduction in the injury, and that is more obviously seen in the DCD donors, but it's also seen in the DBD. But given that the transplant practice has changed, and 70% of the time we're transplanting at night, one of the other advantages of this technology is this. It allows you to assess the organ dynamically, same as the NRP, allowing you to reduce your discard, half of that in the current activity. But this is done against a significantly longer preservation time. And if you look at the machine perfusion time, how long the liver was perfused in the box at the normothermic temperature, like in the body, it's nearly 24 hours. Normally, the liver has to be in by 12, 14 hours at most. So this is the liver that stayed 24 hours in a box and then was transplanted successfully. The holy grail that remains is how do we define again which livers we use, because the machines, be it in the donor or be it in ex vivo, will tell us a wealth of information. And how do we know which ones are important? There's a lot of work going on, and these are some of the suspects in terms of what we think may give us some information, but we really do not know. I think we really need to understand better and push the boundary in transplanting some of the organs that are more marginal. Using a similar approach and a similar concept of normothermic perfusion, again in-house, outside the body, the Cambridge group led by Mike Nicholson proposed a much simpler intervention. 1 hour. You bring the kidney to you, you perfuse it normothermically for 1 hour, and then you transplant it. And what they've shown is that they reduced the rate of the kidneys being asleep from 40% to about 5.6%. But similarly to anything else, because it's normothermic, it allows the kidney to be assessed. And kidneys, although it's a washing machine of the body, is actually a much simpler organ than the liver, dare I say. And the assessment involves how it looks, how much blood flows through it, and how much urine goes through it. And this is one of the first we did here. You see the kidney happily making urine. I'm trying to point this to the liver. The kidney looks actually quite all right. It's red. So this is ready to be transplanted. And we've got a kidney that's going to work. So, is it time to ditch this little fella? Well, probably not, but most likely we may replace it with a different form of a box. And this is it. Much smaller. Because the other option is to really go super, super cool. So this is a group from Boston that showed that actually you can take an organ from the body temperature and within a few hours you bring it to -6. And you put it in the polyethylene glycol, the kind of thing you put in your car, not to freeze. You keep it alive for 4 days, you reheat it, rewarm it, and then you transplant it successfully. So what this really does, it really opens the gate to much wider sharing and actually putting organs on ice for a lot longer and then transplanting them. And I'll let you think about the dystopian reality that can occur from this sort of approach. But this is something which is quite exciting. And finally, the advantage of machine perfusion is that it can be a vector for therapy delivery. And you'll hear from Professor Forbes later on about different options in terms of cell therapies and whatever. Some of them can be combined and delivered on the machine before you actually transplant. And this is a very fascinating way of recovering more organs and reducing damage. There's lots of technologies, but the path from discovery to clinical implementation is fraught with many options and many challenges. I think it requires a lot of collaboration and, more importantly, freedom from commercial interest and belief to be able to choose the right one for the right organ, because we are living in a third revolution of transplantation. Steve has told you about the surgical one, then we had the immunosuppression, now we have the preservation one. And this is going to personalize the approach to how we deal with each organ, because you need to combine the quality of the organ you're going to get with the status of the recipient and preserve it in a way that you give every single patient the optimal organ. So are we making the most of the donated organs nowadays with novel preservations? Yes, and it's a clinical reality because it allows us to understand what we're transplanting, to stratify the risk, and more importantly, to deliver therapies, ultimately leading to a huge expansion of the donor pool. So I would say to you, ladies and gentlemen, that it's time to embrace the future or be left behind. Thank you.
Gabby, thank you very much indeed for giving such a great overview of really what is a genuine revolution in how we manage the organs following their removal from deceased donors. And I think the great example that Gabby's outlined in his talk is about how we're working nationally, very collaboratively between centres, between different organs, to really try and examine how best to take this forward, ultimately and only for the benefit of our patients. So, Gabby, thank you very much for a superb talk. I'm now advised to give you a 5-minute comfort break. Our next speaker is not a surgeon, but we will forgive him for that. Professor Stuart Forbes, who is a fellow of this society, is the chair of Transplantation and Regenerative Medicine and the director of the MRC Centre for Regenerative Medicine here at the University of Edinburgh. And clearly his aim is to do us transplant surgeons out of a job, because he is going to tell us about how to avoid the need for transplant by repairing damaged organs with stem cells. So it's with a degree of reluctance, Stuart, that I invite you to the podium. Thank you.
You won't be clapping when I've finished. Okay, so that's Prometheus being punished for offending hepatologist, which is what I am. And his punishment was to have his liver eaten every day, and he regenerated every night because he had good stem cells in his liver and he didn't need a transplant. Okay, so that's what we're trying to create. There you go. Okay, so I'm been asked to talk about stem cells because I do a bit of stem cell research, and I'm also a liver doctor as well. So just a quick outline of what stem cells are. So there's lots of different sorts of stem cells. These are so-called pluripotent stem cells in the early development phase after in the embryo, before the embryo forms. And these stem cells can be isolated and can grow into lots of different sorts. Or, of course, if an adult is born, a human's born, or any kind of creature, then the cells can differentiate into different cells of the body, and they're called, therefore, sort of pluripotent stem cells. There are also adult stem cells, and the stem cell, really, the characteristic is that it can renew, self-renew, expand, and form clones and colonies, and also be pluripotent in terms of turning into different sorts of stem cell types. So that's basically what a stem cell is. Now, the field, in terms of therapeutic potential, became quite interesting when people discovered this phenomenon of cell reprogramming. And this was first shown by John Gurdon here on the left, who could take frog cells from the tail, reprogram them, and form them into pluripotent cells that then could give rise to frogs. And this was very famously shown by Ian Wilmot, who was a fellow of the Royal Society of Edinburgh, of course, who is still working alongside me in the Centre for Regenerative Medicine, who famously took a cell from the breast tissue of a donor sheep, therefore called Dolly, of course, and this cell was put inside an empty egg and it was reprogrammed, and his team showed that it could form into an entire sheep Dolly, and of course that's been done many times. But where this got quite interesting from a clinical and practical point of view was when somebody called Shinya Yamanaka, who I regret with all my heart to say he's also a surgeon, and he won the Nobel Prize, though, Professor Wigmore, and he won the Nobel Prize by showing that you could take skin stem cells, and with these skin stem cells introduce these so-called reprogramming factors. He had a very clever postdoc, and they screened different types of genes expression in these skin stem cells, and they were very fortunate or very clever, whichever way you look at it, probably both, and these cells reprogrammed into these pluripotent stem cells, very similar to the so-called embryonic stem cells, and they could then be coaxed into lots of different cells of the body, and that really gave us great hope then for a therapeutic potential of these cells. The other type of stem cells are the so-called adult stem cells, and of course we've been transplanting these for many years. So the classic example is the hematopoietic stem cells, which resides in the bone marrow. And when we do bone marrow transplants, what we're really doing is taking the hematopoietic stem cell, which is this one here, which can then divide and form it into all the different blood cells of the body that we required, including the red blood cells, the white blood cells, etc. Okay, good. Excellent. So, this observation that we can transplant hematopoietic stem cells became more realistic when people identified that there were equivalent adult stem cells in many parts of the body, including the gut. Very famously, and this was discovered by Hans Clevers in Holland and Nick Barker. And they showed who's an alumni of Edinburgh, of course, at Edinburgh University, Nick Barker, was a biological graduate, and they showed that these stem cells in the gut could give rise to the entire gut, but more than that, we could isolate a single cell from the gut stem cell, and they would grow as these mini organoids, which had many of the characteristics of the gut. They really had this complex structure. And that opened up the way for us thinking about adult stem cells in many other organs. And of course, my favorite organ is the liver. And we try to sort of replicate this kind of work, the hematology work and the gut work. And we were able to show that we could take a single cell from a mouse liver and expand it into millions of cells. And when we transplant these millions of cells into the mice where the liver is conditioned in a special way, these single cell can grow and regenerate basically a whole liver. So that was a very exciting result in us in a mouse, but the question is, can we get anywhere near that using human, of course? And collaborating with colleagues here in Edinburgh, what we're doing is looking at these fatty livers that are not able to be transplanted because they do very badly. But these fatty livers we find are full of these ductular reactions, which is where we think the stem cells live. And we can now isolate those and grow them as organoids. And this is, here you can see a picture of a single cell developing as a sphere of cells. And here it is that we can now expand indefinitely, really, into billions and billions of cells. Now, just because we have the cells doesn't mean that we know how to use them properly, but we can certainly identify these cells and they stay stable. The chromosomal identity is stable, and they don't become tumors or anything like that. They stay as a safe form. So really, the aim is to try and develop these as a clinical cell therapy, much like Islet cell program runs for people with complications of diabetes, and that would be for people who have complications affecting their bile ducts. Of course, it's many a experiment to go before we're sure that we can definitely do that. The other thing, whilst we were doing this work, we were able to identify that there were stem cells in the liver that could actually spread out and turn into the hepatocytes and regenerate the whole of the liver. And again, we initially showed this in mice, but confirm this again in humans again. And it's like, if I can just share this video. Sorry. Yeah, it's, they spread out like leaves on a tree. So this is like the trunk of a tree. This is so-called bile duct cells, and they really spread out into the whole liver and are able to regenerate both the bile ducts and the hepatocytes. And now that we know that this occurs under certain circumstances when the hepatocytes are very damaged, we can understand the molecular controls of this. And the idea is to try and target this with pharmaceutical drugs to improve the regeneration of the liver from these stem cells to try and avoid the need for transplantation. So that's the other approach that I think we're now working on. Now, the real problem in liver disease, particularly in Scotland, the 95% disease is cirrhosis due to predominantly alcohol, obesity, hepatitis viruses, autoimmune diseases, genetic diseases, whatever the cause, you end up with this severely scarred liver. And it's a real problem in the UK. Deaths are soaring. It now kills more women than cervical cancer. The economic costs are absolutely frightening. The mortality increases are awful. And so there's a real epidemic of liver disease that needs a really multi-pronged approach. And of course, transplantation is one option for people with severe liver disease. But if you look at the numbers here that have been transplanted, 600 or 700, it really isn't touching the iceberg of this disease. So we have lots of people where we can treat the initial disease, we can treat the virus, we can treat the, if it's alcohol, we can get people to come off alcohol, or if it's an autoimmune disease, we can treat it, but they're still left with severe cirrhosis. And they really hang in between life and death, and they're really requiring a transplant, obviously, but the numbers are the problem. And the question is, can we grow stem cells into hepatocytes and then transplant them into the liver? Now, unfortunately, the cirrhotic liver is a really proverbial stony ground, and it really doesn't take transplants of hepatocytes very well at all. We know that. We've done transplants of hepatocytes from livers that we couldn't transplant, and the outcomes are very, very poor. So really, even if we can grow stem cells into hepatocytes in their billions, just throwing them into a cirrhotic liver is really like throwing seeds into the stony ground, and that's not going to work, unfortunately. And what I think we really need to do is take a regenerative approach to this by trying to reduce the scarring and stimulate regeneration in these livers. Now, what we've been able to show, and colleagues of mine have been able to show, is if you take away the insult from these livers, even cirrhotic livers, they can undergo a degree of regeneration. The more damaged they are, the more cirrhotic they are, the harder they find to regenerate. But if there's moderate or mild damage and we stop, they can regenerate reasonably well. And the cells that are helping to do this are so-called macrophages. Now, macrophages are there to fight infection, but they do many other things as well. And in fact, what they do is they remodel scar tissue. So if you have a scar that goes away, it's your macrophages that are eating this material and remodeling it. And they remodel the scar tissue. And they're required for this process. But interestingly, we've also found that macrophages do many other things. They stimulate these stem cells in the liver to be activated, and they also stimulate conversion of the stem cells into hepatocytes. So they do many, many things in actually programming this regenerative response. So because of that, we've been trying to develop a cell therapy program in Edinburgh based on taking out monocytes. And that's me having billions of monocytes removed. Don't panic, because I've got billions of them and I make many more every day, so I'm smiling. So I can get these billions of monocytes and convert them into the so-called regenerative macrophages that we showed in our animal models is able to break down scar tissue and stimulate regeneration. If it works, we'll be very happy because it's an autologous. In other words, it's from your own body and you won't need any of this nasty immunosuppression that causes complications. So we're doing this as a trial in Edinburgh, based out of a Centre for Regenerative Medicine, which is built conveniently close to the hospital, which means we can translate our studies between the lab and the hospital and hopefully very quickly. The liver transplant unit's here. We have an imaging facility and a cell separation facility there. We've gone through phase 1 very well and very safely, and we're now doing the randomized phase of the study. Of course, there's many a successful phase 1 study that fell down in phase 2, but we have our fingers crossed. So finally, I should say that there are a large number of ongoing cell and gene therapy clinical trials in the UK. So it really is picking up very rapidly, and that's partly because the landscape, the government, to be fair, has done a lot to promote a really good regulated trial landscape and to put money into this and to create a network of advanced therapy centres, of which Edinburgh leads on one of those. And of course, it's the right time to do it. The biology is matching the medicine now. It's really attacking many diseases, not just the liver, but just about every type of disease is now a target for clinical trials. These are ongoing in using cell therapy or genetically modified cells. I should say that we're not just giving cells on their own, we're now changing them genetically, because gene therapy is the other thing that went through a bit of a big gap between the theory and the practice. There was great results in animals and then really disastrous results in humans for a while. But now really successful gene therapy is really on the mainstream again. So there's many cell and gene therapy combinations now. So the future, so this is somebody who has a genetic disease called Hunter syndrome, who was, as far as I'm aware, the first person, certainly in the Western world, who had his genes edited in vivo. So he had an infusion of a compound or to actually edit his genes in his liver and turn his liver into a genetic factory and make a missing enzyme that he had. So that's in vivo gene therapy. There's a technology called CRISPR that's just, again, in the last few years, it's gone from being done in one lab, being discovered in the lab, to now being done in literally thousands of labs through the world, and now massive commercial investment. And this has really been used in human cells now, and it's really called the cut and paste of genome technology, where people can replace genes now really successfully. And of course, people are looking to think about, can we translate this genetically? Of course, whilst there's lots of investment in this, there is a downside to this, and there are reports where, and this is reported in China, but other places where people are doing this work rather unregulated. And again, we worry that there's going to be complications of this, and there'll be a backlash if things aren't done properly. So just to finally touch on one of the real futures is bioprinting of organs. So can you print me an organ? So of course now people have seen 3D printing. You can 3D print a gun and shoot somebody. So what you can also do now is begin to 3D print organs by intersecting different cell types on them. And it looks very promising. But of course, I don't mean to throw cold water on this, but really this is likely a very long-term challenge. You think about printing a whole liver, the complexity of it, and we're a few years ahead. So I think we've got to focus on stuff we can do at the moment, which is the regenerative strategies based on the organs we've got, and of course the work you've heard from the other guys. The reason I talk about regulation is even in the US, this isn't done in Mexico, this is in the United States, people going and getting commercial cell therapies, and this is for people who have had stem cells for macular degeneration, And the bad thing is they got the therapy to both eyes at the same time, and they've suffered blindness or severe bilateral visual loss. And that's really through unregulated commercial so-called stem cell therapy for macular degeneration. So although we're enthusiastic about the potential, we must do it in a regulated way. We must give people good information, and we mustn't do it just for a commercial gain. In the UK, as I say, we've got a very good landscape to do this, and this is why there's been so much investment from the international community to do trials in the UK. So long may it last. A neurostem cell is run out of Edinburgh Centre for Regenerative Medicine, and one of the things it does is a website which gives patients who are thinking of having any experimental cell therapy rational advice, and he does a lot of reach out to people to try and give them advice about where to go and where not to go. So that's the Centre for Regenerative Medicine. It's where I work. It's a good building. It's got a GMP facility, so we can do cell therapy and take that across to the clinic. But what really makes it work is a great research staff. So I'd like to thank you for your attention and pass on.
Thank you very much indeed for a fascinating talk about an area which really is, again, cutting edge and I think at the forefront of having the potential to make real difference for our patients. Our last speaker this evening has travelled somewhat further than the rest of us, even further than Nawar, who came from Glasgow. And I'm delighted to invite Professor David Cooper to the podium in a moment. Having undertaken his undergraduate and early postgraduate medical training at Guy's Hospital in London, which I also struggle with because I'm a graduate of St Thomas's Hospital, which was an arch rival hospital at the time, although of course now we're all combined and a happy family together, so that's fine. David then travelled to the University of Cape Town, where he worked in the heart transplant programme under the very famous Professor Christian Barnard, and more recently has established himself as the Professor of Surgery and Co-Director of the Xenotransplantation Programme at the University of Alabama in Birmingham. So you're very welcome, and we look forward to your talk on bringing home the bacon. Thank you.
Well, thank you very much for the invitation to come here. I've enjoyed very much the evening's speakers because I've learned a great deal myself about what's going on in the field. So I'm going to talk about a different subject, and that is that whether we can actually solve the problem of this organ shortage by using pigs as the donors of the organs. Now, what I'm going to talk about, of course, is a work of a lot of people, not just me, and going back 30 years or so, I have no conflicts of interest. Now, today I'm a real expert because the definition of an expert in medicine is a guy from out of town with slides, and that's me. I'm the guy from out of town with slides today, so I can say I'm a real expert. Now, some of you will know David Wheatley. Professor Al Attar was David Wheatley was one of his predecessors, and I used to be a heart surgeon, and he had a very good quote. I'm sometimes reminded of the differences between a rhinoceros and a cardiac surgeon. One has a thick skin, a small brain, and charges a lot. The other is a large animal that lives in Africa. So you don't get too much wisdom out of most cardiac surgeons, that's what he's saying. Now, here's a report from 1984 of what people think about when they're in these meetings that we're here like today, a medical conference. And it says here that 10% of people attending the conference actually listen, 20% are physically present but mentally elsewhere, 20% are asleep, and the rest are indulging in sexual fantasies. So when you wake up in 10 minutes, you have to think which group you're in. And it also says here that we know that a male speaker has about 27 seconds to grab his audience's attention. That's how long it takes before they decide whether to turn off. A woman speaker, presumably because she's better looking, has a bit longer, about 55 to 60 seconds. So I put this slide up in first 27 seconds in order to capture your attention and try and hold it a little bit longer. Now, you've seen the data from the United Kingdom today, and this is the data from the United States. You can see a lot more people waiting for a transplant, around 120,000, maybe tailing off a little bit like we saw in the UK, but it's very high. And the number of donors, these are brain dead and deceased, circulatory deceased donors, is creeping up slowly. And the number of transplants is perhaps getting close to 30,000 a year, but you can see there's a big gap between the two. And as we've heard, that many of those patients either die while they're waiting or don't get a transplant for some reason or other. And that's just the tip of the iceberg. There are, for example, at least 500,000 people in the United States on chronic dialysis for renal failure. And they're the people that probably some of those should go on this waiting list, but nephrologists are reluctant to put them on the waiting list because they know how long they're going to wait. And if you look at dialysis, and we tend to think that people on dialysis are going to live an average life, but they've got the inconvenience of being on dialysis, but that's not true at all. 5 years after you go on dialysis, only 41% of those patients are still alive. And as you wait on average in the United States for a kidney of 4 years, that means by the time your time comes up for the kidney, the donor kidney to be arrived, most of you or half of you are dead. So it's a very bad situation. If you have a kidney transplant with a deceased donor, you've got a 76% chance of being alive at the end of 5 years. And if you have a living donor, you've got an 88% chance. So the results are so much better than people on dialysis. And that's the group we're going to target first, I think. So we've thought, and several other groups worldwide have thought, can we transplant between the species? Can we do, for example, a pig organ transplant? The organs are very similar in structure and function to human organs. And can we do a transplant from the pig to the human? And so let me give you a very brief history of xenotransplantation. We go back to the Greek mythology, and we all know of these wonderful mixture of animals. Here's a lamassu, which clearly is a mixture of a bird and a bull, etc., etc. So we've had this idea of mixing the animals together for a long period of time. And as far back as the 17th and 18th centuries, people received blood transfusions from animals. Here's a donkey as a donor, but in fact the sheep was very popular because it was thought the sheep was very docile, and a lot of patients with mental disease had sheep blood transfusions because it would calm them down, the sheep blood. It probably killed more than it calmed down, but it was quite popular up until the First World War, in fact. And here on the left is Alexis Carrel, a French surgeon who specialized in research in the United States. And with him is Lindbergh, Charles Lindbergh, who was the first man to fly solo across the Atlantic. And they worked together on trying to develop an artificial heart, actually. But Carrel was a very visionary person and was really the founder of transplantation surgery in many ways. And he said the ideal method would be to transplant in man organs of animals easier to secure and operate on, such as hogs or pigs, for instance. But it would in all probability be necessary to immunize organs of the hog against the human serum. So he knew that the human serum was going to damage those pig cells, those pig organs, and he said we've got to develop a method of protecting the pig organ from the human blood, which is exactly what we're trying to do today. And he said the future of transplantation of organs for therapeutic purposes depends on the feasibility of heterotransplantation, which is the old word for xenotransplantation. So in 1907, he got it absolutely right, and what we're still trying to do now more than 100 years later. So he was a great visionary, and it's no surprise that he won the Nobel Prize for his work in this field in 1912. And then in this brief history, we come to Sergei Voronov, who had the vision to say of what we've heard today with pancreatic islet cells, that if you could put the cells in that make a hormone or an enzyme, that would be better than just treating the patient. So if we could put the pancreatic islets in, instead of giving the patient insulin, allow those islets to make the insulin for themselves. But he had a slightly different approach. He looked at aging gentlemen, people of my age and so on, and he saw that they were running out of steam, so to speak. And as Viagra was not available at the time, he suggested we have chimpanzee testicle transplants. And he carried out a large number of these in Paris, and it caught on both in Europe and North America. And another surgeon carried out goat testicle transplants. And he reported some people really rejuvenated by this, elderly gentlemen who really were rejuvenated, took up sports again, and so on and so on. So it was the Viagra of the 1920s and 30s. Now, if you look at him closely here, he looks to me as if he needs a bit of chimpanzee testicle himself. But in fact, and this is absolutely true, at this stage of his life, his wife had just died. She was a Texas oil millionaire. And I know people in Paris now still doing research on the money she left his department. And he had just married, at the time this photograph was taken, he just married a 21-year-old French girl. And I think this is why he's looking a little bit jaded, not because... But I make fun of him, but in fact he was a man ahead of his time. He would have done the first kidney transplant if the authorities in Paris had allowed him to use somebody who was being having their head chopped off, but they wouldn't let him use the kidneys from that patient. So, and then we come to Keith Reemtsma, who was a good friend of mine, who sadly died a few years ago. When he was a young man in Tulane University in New Orleans, he carried out 6 kidney transplants between chimpanzees and humans. It was at a time when getting a human donor was very, very difficult, and the dialysis had not come in. 1963, this was. And one of those patients, most of them died after about 6 weeks, either of rejection, because he had very primitive immunosuppressive drugs, or from infection. But this patient lived 9 months, went back to work as a school teacher, did very well for 9 months, and then died relatively suddenly, probably from an infection, but an electrolyte disturbance made it impossible. He put in both kidneys, both chimpanzee kidneys. So here are both kidneys cut across at post-mortem, and here are our own very diseased kidneys. And so even back in 1963, with very primitive immunosuppressive therapy, one patient lived 9 months with a chimpanzee kidney. And so if we use chimpanzees today, we'd probably do very well. In 1964, James Hardy went to visit Keith Reemtsma, and he saw one of these patients with chimpanzee kidneys in, and he decided he would put a chimpanzee heart into a patient who was dying. And here's a picture he gave me of the heart at the time of the transplant, but the heart only survived 2 hours, probably because it was too small, but also because it probably underwent some early rejection. And interesting enough, this is the consent form that the patient's family signed. The patient was semi-comatose, so he would not be a candidate for a heart transplant today. But they got the family to sign this consent form. You can't read it from where you are. It does state that no heart transplant has ever been done before in the world, but it makes no mention at all that they might use a chimpanzee heart as the donor. Today, you can think of the legal repercussions of doing that, but that was the norm for the time. And then Leonard Bailey, who's still alive, and sadly not as well as he used to be, but he's still alive, and he carried out the baby Fay baboon heart transplant in a baby back in 1983, 84. And this got huge publicity worldwide. Those who are old enough will remember it. And interesting enough, he received, and the hospital received, 300 letters complaining of using a baby for this experiment, really. It was a clinical experiment. But it received 17,000 letters complaining about using a baboon for this experiment. So you can see the public reaction in the United States at that time. The baby lived 20 days and then died of rejection. It didn't do much for xenotransplantation, but it did do a lot to raise public awareness of how difficult it was to get a donor heart for a baby. And after that, he was able to do a series of transplants in babies using human donor hearts, and they've done extremely well, better than any other group of transplants. For example, 25 years later, 60% of his patients are still alive after a single heart transplant, which is remarkable. So the animals, the primates, got a bit worried about that we were going to use them for a while, and this really concerns some of them, but we've decided that they're not the ideal, and that probably the pig is the perfect organ source. And what are the advantages of the pig? Well, there's an unlimited supply of donor organs. With non-human primates, you'd have to breed them in large numbers. It would take years. For example, a baboon takes 9 years to grow to its full size, etc. And even then, it doesn't grow more than about 40 kilograms, whereas most adults are at least 70 or 80 kilograms. So it would not be very good to have non-human primates. But pigs grow very rapidly. They're adult human size within 6 months, and they start breeding within about 4 to 5 months. So we could have large numbers. We could have the organs electively. If you come in today with kidney failure, you won't go on to dialysis. You will have a kidney transplant tomorrow with a pig organ. That's the plan. And as we've heard today, many of the organs from human donors, if you've undergone brain death, you undergo quite a bit of damage to the organ during the brain death thing, and there's a lot of hormonal changes which can be detrimental to the function of that organ soon after you transplant it. The pigs will go to the operating room and be anesthetized, just as any patient would be anesthetized, without undergoing brain death, will not suffer all this injury. And every day we do transplant a human organ, we run the risk of transplanting an infectious agent with the human organ. So there's several viruses that we routinely transfer from the donor to the recipient. If we didn't, we wouldn't get any donors. And some of them can be detrimental to the outcome of the patient or to the graft. But theoretically, with pigs, we should be able to exclude all serious infections because we will be breeding those animals and monitoring them until the time we take their organs. So they should be much better than human ones. And then a number of other things which are less obvious. When I ran a heart transplant program, I saw about 140 patients a year. I would select about half of those to go on the waiting list, and I'd transplant less than half of those. But the group I turned down, they were either not sick enough to a transplant, but more commonly, they had other problems that I thought would be detrimental to the outcome. They might have severe peripheral vascular disease or cerebrovascular disease. I thought they're going to get a stroke after the transplant. They might have very severe diabetes, which was going to be very difficult to control. This was 20 years ago. But I was very selective because I thought you've got to use the donor for the best possible candidate to get the best use out of it you possibly can. We wouldn't have to worry about that if we have unlimited donors. We can say, well, this patient's probably not going to do well for more than 2 or 3 years, but he's going to have a good quality of life during that time. We can give him this transplant because we're not taking a donor away from somebody else. And in some countries, such as Japan, where they have all the technical ability to do this, they have a cultural barrier to deceased donation. The number of deceased donors is very small, so all their transplants are done with living donors, either kidneys or partial livers, as we heard today, but they can't do heart transplants, obviously, unless they have a deceased donor. The number of transplants done in those countries would increase enormously because they have the expertise, but they're just short of donors. And then when we look at diabetes, as we've heard about today, in the United States, there are probably 1.5 million people with type 1 diabetes, juvenile diabetes, which is the unstable variety of diabetes. You're never going to get enough human donors to give all those patients transplants. But with pigs, you could get as many islets as you want to do the transplant. So when we're talking about, and there are other conditions like Parkinson's disease, we know from experimental work that would be susceptible to a pig cell transplant. But we're talking of very large numbers of patients, which we will never solve if we only use human donors. If you want a large number of pigs, you can treat the pig hormonally. Here's one with a litter of 29 piglets, if we wanted to really expand the numbers that we're going to get. So we've been interested, a lot of others, in organs, particularly the heart, kidney, liver, and lung, islets for diabetes, corneas for corneal blindness. In China, for example, there's said to be 4 million people waiting for a corneal transplant, and they don't have enough donors for that. Neuronal cells for people with Parkinson's disease, hepatocytes, as we heard today, or skin grafts, and red blood cell transfusion. I believe that one day all our transfusions of red blood cells will be from pigs because of the advantages they have. But there are a lot of problems. The immunologic problems, the rejection problem that we've heard about today is the biggest one, but the other things are physiologic. Will those organs function normally if they're transplanted into a patient? Will they do all the things that a human organ will do? And we don't know all the answers to that yet. What is the safety? Is there a risk of transferring a pig infection to the human, which we think is pretty low, but there's a possibility. And then there are ethical, regulatory, and legal problems. So let's look at the barriers, which is mainly rejection. The rejection of a pig organ is much more complex than that of a human organ, which we call an allograft. For example, number 2 here, T and B cells, is the rejection that we heard from Professor Wigmore this morning, which is the main way you reject a human organ. But with the pig, we have several other approaches as well, several other ways of attacking the organ. First one is antibody and complement, which I'll come back to in a minute. Coagulation, dysregulation, you get clotting in the organ, and as an inflammatory response. So it's much more complex than overcoming the rejection of a human organ. The first one is antibody-dependent, complement-mediated, hyperacute rejection, means it's very rapid rejection, and it can occur within 5 minutes. And what is happening is that the pig organ, here is the pig vascular endothelial cells on the surface of the blood vessel of the pig. Coming out from it, it has some carbohydrate antigens, just carbohydrate structures like glucose, except they're not glucose. The most important one is galactose, but there are 2 others. And we have antibodies directed against those antigens, which we developed during infancy as a response to bacteria and viruses that colonize our gut. and we develop them as a defense mechanism, and they bind immediately. You put that pig organ in, and they activate what's called a series of proteins called complement, and the complement bashes holes in this vascular endothelium, destroys the whole organ. It can occur very, very rapidly. And so this is a problem we have. Here's a pig organ being put into a baboon, and here it is 5 minutes later, completely destroyed with hemorrhage and clotting and so on. And here's a pig heart put into the abdomen of the baboon, because if it rejects, we can take it out and the baboon can still be alive and we can follow the baboon afterwards. And here it is 5 minutes later. You can see black thrombus in the cavities of the heart, completely destroyed. And if you look at it histologically, the pink are the myocardial fibers, the muscle fibers in the heart. And you can see all these red blood cells in between all these fibers, because all the blood vessels have burst because of this complement activation, and they've destroyed, they've moved into the muscle and destroyed the whole thing, so it stops functioning. Now, Randall Morris, a friend of mine who was a cardiac surgeon in research in Stanford University, he said there are 3 golden rules for achieving successful xenotransplantation. But then he added, unfortunately, we don't know any of them. Now, since he said that, we do know some of them, so we're getting somewhere. And fortunately, humans are very curious people. They're very into research. And so luckily, we have these budding research people. Now, they don't always find the answer to what they actually expected. Sometimes it's a bit of a shock to them, but at least they're into research. And Klaus Hammer, the late Klaus Hammer, who was a surgeon and a veterinary surgeon, he said the phylogenetic distance, the evolutionary distance between man and pig, comprises 80 million years. It's 80 million years since they divided to go their separate ways. And so what we're trying to do is to outwit evolution. We're trying to bring them back together again, which is quite an undertaking. And so that's why it's taken us a long time to get this far. Now, this is probably the most important slide I'm going to show you today, because it's very simple, but it's the first time in transplantation that we are able to modify the donor rather than just treat the recipient. And that's very, very important. With the genetic engineering techniques, some of which result from Dolly the sheep from Edinburgh, from the technology used there, with those technical genetic engineering techniques, we can actually do 2 things. We can breed a pig that doesn't have these sugars sticking out. So there's no target for human antibodies, which means then the complement activation will not take place. But furthermore, we are protected from our own complement because we have complement regulatory proteins in our blood vessels. Pigs have pig complement regulatory proteins. They're not very effective against human complement. And so we can add the human complement regulatory proteins to the pig. So if there is any complement activation, they're protected from it as well. So we can do 2 things, and here they are summarized again. We can knock out the major pig antigens, and we can provide protection by inserting human complement regulatory proteins. And we can do human coagulation regulatory proteins, human anti-inflammatory proteins. We can do all sorts of things like that we need to do. And here's an example. If you look here, this is IgM binding, antibody binding to a wild-type pig. That's a non-modified pig organ. You can see it goes up to, 20 plus. The binding is 20 on this scale. If you knock out one of those antigens, those carbohydrate antigens, it drops to 4 or 5. You knock out a second one as well, and it drops to less than 2. And I haven't shown you here, but the third one will drop it down to the same binding of human antibodies that bind to human cells. So we're now down in the same scale as an allograft. We're down with no more binding to that organ than we would have to a human organ. So we've made very good progress. And these pigs, fortunately, are healthy, and they breed normally, and so it's not a problem to the pig. And you wouldn't expect it to be, because we don't have any of those 3 carbohydrates, and we do fine without them, and the pig does fine without them. So then we come to the problem we face with allotransplants. That is the T-cell response, the cellular response, similar to after a human organ. And luckily, there are new novel immunosuppressive agents, which we call co-stimulation blockade monoclonal antibodies. They're a new approach, and they seem to block this T-cell response to a pig organ very efficiently, much more efficiently than the conventional drugs that we're using today in transplantation. We could, in fact, solve the problem by further genetic engineering, because most of these cells are directed to what we call MHC antigens, and we can knock out or knock down the expression of these antigens in the pig, so we don't get that response by the T cells and so on. And we can actually even express an immunosuppressive drug in the pig organ. We've expressed CTLA-4 Ig, which is one of these agents, in the pig organ. And so we would have to give less drug to the patient because the pig organ is protecting itself to some extent. So there's a lot of things we can do. And so where are we? Well, life-supporting kidneys, that's in a baboon with, say, a single pig kidney. We've now got a survival over a year. Non-life-supporting hearts, as I mentioned in the abdomen, over 2 years. Life-supporting hearts more than 3 months, and most of those are technical problems rather than actually rejection problems. And with diabetes, we've got over 2 years. Monkeys with diabetes are cured of their diabetes for more than 2 years just by transplanting with pig islets. And here's 2 examples. This is 2 kidneys that we did recently. The normal level of the creatinine, which is a measure of kidney function, is between these 2 lines. And you can see these 2 baboons have got creatinine levels for up to about 9 months within that normal parameter. We had to stop the experiment because both of them got some infection, and we decided to euthanize them instead of treat the infection. And here's a monkey, a diabetic monkey, with islet transplants. Here you can see in blue is the blood sugar. As soon as we put the islets in, the pig islets, the blood sugar is in the normal range for a year, and then we euthanize the baboon. So we're doing very well. Now, you may worry, should we use pigs for this purpose? But in the United States, 100 million pigs are used per year for food. In China, 500 million pigs are used per year to produce the anticoagulant drug heparin. And worldwide, we've been using about 250,000 pigs per year for heart valve replacement. The heart valve is processed and is not susceptible to rejection as the whole heart, although it does undergo some rejection slowly. So we're using pigs on a big scale for our own purposes, so I don't think there's any problem in using pigs for this purpose. Now, pigs may still have a few tricks up their sleeve, and we need more research. And I like this phrase: there are many ways of losing money. Women are the most fun, gambling is the fastest, research is the most certain. And so we still need a bit more money for the research. And many years ago, I was in Oklahoma City, and for a South London suburban boy, I tried to be as good an Okie as I could be. And I was very impressed with this Native American proverb there that says timing has a lot to do with the success of a rain dance. There's no point in running out and doing a rain dance unless you're pretty sure you've looked at the Weather Channel beforehand. And I think with xenotransplantation, timing is now just right because we have all the technology and we have the new drugs that we need to make this successful. So I'm sure it's going to be successful in the near future. We heard of Tom Starzl before, one of the great founders of transplantation. He was a colleague of mine in Pittsburgh for many years. Sadly, he died last year. And he said, back in 1982, history tells us that procedures that were inconceivable yesterday, like xenotransplantation, and are barely achievable today, still like xenotransplantation, often become routine tomorrow. And I think xenotransplantation will become routine tomorrow. So one day, making a pig of yourself will take on a whole new meaning. And finally, I like this quote from George Orwell's Animal Farm: the creatures outside look from pig to man, and from man to pig, and from pig to man again, but already it was impossible to say which was which. And I think eventually you will go into the patient's room and you will not know whether that patient's got a pig kidney or a human kidney, because they will be doing just as well as each other. Thank you very much.
Thank you very much indeed for another fascinating talk. I'd like to invite all of the speakers. We have some time for questions. A little shorter than expected, but that's primarily because of a prolonged comfort break rather than because of any of the speakers that overran, I would just like to say. If you have a question for any of the speakers, please do raise your hand, but please also wait until you are given a microphone into which you might ask your question. If you could hold that microphone close to your mouth, it will work better. And keep your questions brief, please. And if you can mention your name, that would be great as well. Thank you. Any questions?
Thank you. I'm Dorothy Crawford, Emeritus Professor at the University of Edinburgh. I'd like to ask Professor Cooper about the pig transplants. I read somewhere that scientists were using the fibrous scaffold of a pig liver and infusing it with human liver cells and getting them to regenerate a liver which wouldn't have all the immunological complications. I wonder if you could comment on that.
Yeah, well, my colleague might be able to say more about it than I can.
Oh, okay, sorry.
My concern is that you can put those cells, as was mentioned, into the liver scaffold around it, but are all the cells going to go to the right place? Because you've got endothelial cells got to line all the blood vessels. You've got bile duct cells got to line the bile ducts. You've got hepatocytes got to do all the manufacturing and so on. So I think it's a very difficult task, and I think it's going to take quite a long time to be able to achieve that. In the meantime, I think we already have a pig liver, and if we can now get over the immunological problems, we have a ready-made pig liver, which we know does pretty much the same as a human liver. Do you have a comment?
Yeah, so this was the famous D-cell resell program. So it looks fantastic on the outside. It looks like a liver, but unfortunately it doesn't. If you cut it up and look inside, you don't get the complex three-dimensional structures. So really, you know, you have to have endothelial cells, stellate cells, Kupffer cells, hepatocytes, inflammatory cells, all lined up in exactly the right thing, and they're not at the moment. It may actually be achievable if we combine it with 3D printing, for example. So, but it's just not there yet.
I can add one comment. There is an alternative approach, which is you grow an organ, a human organ in a pig. So essentially you create an animal that is deficient of a particular organ, and you insert genes from a human that will develop that specific organ, and that's been trialed. So that may be another approach.
Thank you. Any other questions? Leslie.
Professor. Hello. Professor Cooper said one of his most important slides was about modifying the donor. My question to our transplantation surgeons on the panel is, should we be cooling our human donors?
That's one for you,
Gabby, I think.
So Leslie's question is, it's a little bit tricky because there has been one study in the US where they've shown that if you let the temperature of the donor go from normothermic 37 to about 35, not a lot, you actually get a better function in the kidney. What we haven't seen yet is what the impact on the other organs are. Now we know from our esteemed cardiothoracic surgeons that they will do the operations stopping the heart, cooling the organs, and including, in fact, cooling the brain to allow it to sustain. So there may be an option. I think the solution is slightly different, is how do we reach that temperature? So it's coming from normothermic even to 4 degrees, but if you're coming in a slow curve and then rewarm slowly, pretty much as I've shown you what happens with supercooling, I think that is perhaps a better solution. So I think it'll be a multitude of options, including the one you say. I think we still got a lot to go.
Yeah.
I've been learning a lot this evening as a mere physicist. What I did wonder is you joked, Chair, about Stuart putting you all out of business. But I mean, in 100 years' time, would you expect there still to be this physical process of transplantation, or do you think ultimately those sorts of approaches will win out?
I'm going to ask the expert panel to answer that.
I mean, I think it's quite possible. Medicine's advancing at such a rate that as I think Dr. Cooper said, there are things that we couldn't even get our heads around 20 years ago that are standard of practice now. And really, there's just a sort of a technology gap which needs to be overcome in terms of getting functional units of organs. And I'm sure that Stuart will have that sorted out in the next few years.
And can I just comment on that? I suppose for an organ like the heart, where besides the emotive part, and a pump would do the job. So a combination of a biological surface but a mechanical structure would do what it wouldn't love anybody, but it would circulate the blood, and ultimately, I wouldn't advocate that, but you saw the VAD, the ventricular assist device, and there are total artificial hearts. The problem with these devices is the lining isn't compatible, and clotting and strokes and issues like that are problematic. But if we were able to line a mechanical pump that would go on forever, beside it, on the condition, of course, that it got the energy supply that it needed, then we could replace a heart with a biomechanical structure. Thank you.
Yeah, one final question.
These incredible transplant operations that we've been hearing about tonight must be extremely expensive, with allegedly the NHS in crisis over funding. What runs out first, the money or the transplant, the donor? Any comment on funding?
It was a good question, and there has been a lot of looking at funding. So in renal transplantation, kidney transplantation, it's actually a cost-effective solution because it's much cheaper to have someone transplanted and be maintained on immunosuppressant drugs than it is to have them being maintained on dialysis. And we also know that they benefit for a much longer period of time. The average survival for a recipient of a liver transplant at the moment is 22 years. So that's a really considerable life gain. And we don't transplant people just to make them a little bit better. We expect them to go to university, get degrees, get married, have families, do all the things that normal people do and go back to work and contribute to society. So actually, I think that organ transplantation is exceptionally good value for money. As several speakers have mentioned, unfortunately, we don't have the resources to treat everybody who needs an organ transplant, but for those lucky enough to get one, it's really good value for money.
Can I just make a comment on that? Of course, with xenotransplantation, the limiting factor with allotransplantation is the number of donors. You can't do the transplant, so you can't spend the money unless you have an organ. But with xenotransplantation, we have limitless organs. You're going to do far more transplants. And they are expensive in the first year. They're certainly not as expensive as chronic dialysis, as we've heard, but it will raise the bar a bit. And if you're going to double your number of transplants or triple them, you're going to have more money for those patients. In the long term, it will save you money because they're going to do so much better than if you in and out of heart failure, in and out of liver failure for a few years. But it will cost something to start with.
Thank you very much indeed. I would like to close proceedings by asking Professor Mandy Mcclain to come up and give a vote of thanks. But before I do that, I would just like to offer my personal thanks to all of the speakers this evening for a fantastic group of talks and also for keeping so well to time. I think it's been a really interesting and exciting evening. So, Mandy, thank you very much.
Yes, well, I think you'll all agree that we've had an absolutely fascinating and tour de force this evening of transplantation. We've covered the history of transplantation, an overview of the various types of transplantation. We've had heartbreaking stories. We've had a very heartwarming story. We've learnt about the new machinery technology, preservation techniques, stem cell, regenerative medicine, genetic engineering, and then we ended up with a lot of porkies and a lot of men in the audience with crossed legs. Anyway, to be more serious, what I'd really like to do on behalf of the Royal Society of Edinburgh is thank the chair and the speakers very, very much for your presentations, and not just your presentations, but I think all of us would agree, all of us are touched by transplantation in one way or another, but thank you so much for all the fantastic work and research that you all do and to improve transplantation across the world. Thank you very much indeed. And I'd also like to add my thanks to your teams, because I took that home with me, that the teams that work with you are equally as important. So thank you to them also. Right, there's a few other things I need to fulfill this evening. One is to tell you that to always keep an eye on the RSE website for other lectures and events for the public. You will find details on those on the website regularly. You're also going to be sent an email asking you to complete an evaluation questionnaire, and this is quite important to the RSE as a charity. So if you could please respond to that. The final task I have, I'm told, is a bit of an experiment. And what it is, it's a novel evaluation. I'm hoping that I might get some prompts here. It's a novel evaluation online system. And what I am asked to ask you, for people who have, this is the expert, you can tell I'm guddling here because I'm not a techie person.
So you just need to press these arrows.
Where do I press
Ask
it?
everyone to log in, and then when they're ready.
Okay, so what I have to do is get your iPhones out now. You can turn them back on, if you don't mind, having told you to turn them off. And could you log on to the RSC Wi-Fi password? If you can log on to the RSC Wi-Fi. Is everybody there? And the RSC Wi-Fi password is on the back of your program. Is it up there? Is it coming up there? But do they have the password?
You should have it on the
You
back.
should have the password. Okay, so is everybody logged on? Okay, I'm just assuming people are logged on. All right, good, good. So now I have to ask you to go to this website here, www.menti.com. Do you want me to do this here? Okay. And then use the code 298854. Should this be coming up here? Yeah. Okay, so now you have a series of questions. You have 3 questions which we would like you to answer. That's great. Yes, no, unsure, would rather not say. Or still can't log in, whatever. Still trying.
He's put spaces in.
I think that's great. That seems to be working fine. So the next question is, what 3 words would you choose to describe the discussion this evening? Please be kind. The speakers are all here. So I'm going to wait for... Oh, there we go. Fantastic. Carry on. There was 20 of you. Heartfelt, that's a good one. Heartwarming. That's wonderful. Thank you. Okay, that's oof. I'll get in the hand of this now. 27, 30. Okay, I think we've maxed out. That's. Don't what you call that again? It's got a fancy name.
It's a wordle.
It's a wordle. It's a wordle. That's a wonderful wordle. A heartwarming wordle. Okay. And the last one, which I'm going to leave you with, because we don't want to be standing here for too long, you can take your time over answering this as we filter out. And more specifically, how will you use the information shared this evening in your own profession? So I will leave that one with you to sit and ponder and fill in. And once again, I'd just like to thank the chair and the speakers for a fantastic evening.